Good morning, everyone, or good evening, or good afternoon, wherever you are. My name is Richard Wamai. I'm a professor at Northeastern University in Boston, here in the US. And I would like to welcome you very much for this special event of our satellite for the CUGH Global Health Operations Committee. We are pleased to have all of you join us for the next 3 hours. We have an exciting program ahead. Anna, please, would you move to the next slide? Yeah, so there are some logistical issues for all of us to be aware of. Please keep your microphone mute unless you're speaking. As already noted, we are recording this session. If you have any question, you could use the unmute button to either comment or then put a comment in the chat function. And you can use the toolbar at the bottom of your screen for mute video and chat. And the meeting is recorded as already noted. Okay, and here are some just logistical issues. Again, the way you can use your computer to mute. Let's move on to the next slide, Anna. And then in case of any technical difficulties, you can reach out to myself. I'm one of the moderators together with Anna Hellover, and our emails are here. Okay, so our section today, we have called it Rethinking Global Health Operations for an Accessible and Equitable Strategies. This is aligned with the CUGH Conference of 2024, which will be happening next year in the spring. And in context of that, we would like to speak briefly about our Health Operations Committee. So Anna, the next slide. Yeah, so the Global Health Operations Committee is one of 8 standing committees of CUGH. We are dedicated to identifying, developing guiding principles to enhance our institutional aspects related to administration, other aspects of doing global health, including programmatic priorities, education, research, and services. And we try and aim to develop strategies to effectively respond to global health challenges and opportunities that we see, including managing international risk, thinking about legal frameworks, and also thinking about how we can improve and develop and nurture our global partnerships with partners from around the world. The next slide, Anna. Yeah, we have these subcommittees that members from our committee constitute. So our membership is about 25. Anna, you can correct me if I'm wrong with that. But yes, we split ourselves into these committees. So we have small working groups that deal with certain issues. And you can see our current arrangement is focusing on these aspects of administration oversight, best practices, communication and exchange. We have also had a travel toolkit, which we have developed. It's on our website, and also some work that we have done on voices from the Global South, which we'll be sharing in this satellite today. So the objectives of our session is to define more inclusive, equitable governance and operational frameworks across high-income countries, low and middle-income countries, and also to identify or highlight challenges and opportunities, and also aspects of that we can deploy to improve our operations across these 2 regions. Then hopefully we can also be able to identify unique issues, including those that face members of CUGH from around the world to participate and be informed about health operations that are facing our institutions. So We think that areas that may need immediate attention that the committee can work on, can discuss, can bring to the board of CUGH that could be addressed. We are committed to trying to build sustainable and equitable relationships and looking for solutions that can enhance our global health operations. And the outline of the session, we have 3 sections here. Part 1, which will be coming up right after this, my commentary here, will be led by Anna Hellover, which is introducing and discussing global health operations, raising questions that we've heard from members. Part 2, which I'll lead, will review committee activities, including products and some outputs that we have developed over the past few years. The 3rd section, we have a guest speaker from the NIH that will address operational challenges and equitable solutions in global health funding, and then we'll have concluding remarks at the end. So we welcome you again and look forward to having this 3-hour engaging session with all of you. Thank you. Anna, over to you.
Hello, everybody. I would like to welcome you to today's sessions. I'm Anna Helova, and I'm at the University of Alabama at Birmingham in the United States. I'm honored to be a co-chair of this committee along with Richard, who just introduced our committee. Thank you so much to everybody who has joined us today. So let me just start our discussion and session with some of the thoughts about global health operations and where we need to go, what we need to prioritize. So let us help us to define that. Before we go into this discussion, please respond to our poll so we know who is currently attending our session. So Tayaba, could I please ask you to launch our poll?
Yes.
Thank you. Right, so if you would respond, and if you notice, we have multiple choice with all of the questions. So feel free, if you reside, for example, both in the United States and Africa, please feel free to check both of these options. And we know the map as the World Bank defines the region is not always accurate, but this is the distribution how the World Bank categorizes regions of the world. Okay, thank you so much. Thank you so much for responding. Yeah, so please, my co-host, please leave Dalal in the waiting room. Okay, thank you so much for responding. Okay, we will close the poll soon, but please let us know. Please let us know where you are and your affiliations. Okay. Do we still have active responses going on?
Not really.
Okay. Could you end the poll and display the results? Okay. Okay. So so as you can see from a just very brief, quick poll, we have about 67% of participants are currently residing in North America. About 20% are from the Sub-Saharan Africa. We have 7% from Europe, 7% from Latin America and Caribbean, 3% from East Asia and Pacific, and 3% from Middle East and North Africa. So I think that we have a very nice distribution around the globe. So thank you so much for joining. We love that we have all these perspectives on our issues. And about 73%, about 31% consider themselves to be a resident of an LMIC country. So most people, understandably so, since we are a consortium of universities for global health, 73% of attendees of today's sessions are from academia, 18% are representing NGOs, 5% private company, and then we have 14% who didn't find all the other options as their affiliation. So thank you so much again for helping us to answer these questions. Okay, and let's continue in our presentation. Okay, so when we thought about preparing this session and the content of what we would like to share and our goals of this session, we thought that maybe it would be good to remind ourselves of what is really global health. So I don't think that I need to emphasize it too much to this room, but as a reminder, global health is an area for study, research, and practice that places a priority on improving health and achieving equity in health for all people worldwide. So everybody in the whole world is really the focus of our interventions, of our work in global health. The key dimensions that we usually discuss when it comes to global health is equity, global preventive medicine, public health and primary care, cross-cultural sensitivity, and also interdisciplinarity. Okay, so when we discuss what are the global health operations, who is the global health practitioner, how do we really define it? Is it really everybody who works in health, in public health? How do we define it thematically, population that we serve, geographically? So, for example, some common scenarios that might be, where we might question, is this global health or is it really the local public health? Could be, for example, a clinic manager in Nigeria in LMIC setting, focusing only on a local population. Is that global health? High-income country physician focusing on health services provided to refugees. So this is a physician in high-income country, but the refugees is usually a target population that we often address in global health. What about the rural Alabama practitioner in the United States, focusing on local population, but really noticing and focusing on reducing health disparities? So are all of these global health activities or not? Is it time now to really look at the definitions of how we are defining global health? And so that leads me to the topic really of today's discussions, rethinking global health operations. So currently CUGH defines the global health operations as some administrative functions, processes, and services that are vital to effectively supporting the global health enterprise. And our committee works to identify and develop guiding principles to enhance university and organizational administration's procedural and financial alignment with programmatic priorities in global health, education, research, and service activities. So we focus on some strategies and best practices and some of the things that we mentioned, but it's not inclusive of all of the things that we are focusing on, is managing international risk, developing legal frameworks, establishing and sustaining global health partnerships. So before we go to our next session, I would like your input, and Tayaba, if you can share the whiteboard with the rights for all of the participants to edit the whiteboard. Okay. So let's see if this is going to work. It's always tricky to incorporate this in a big Zoom session, but let's see if you can help us to see, you see the definitions that we have here in our focus. Do you see anything from the current definition, from the current focus, that you think that it's something that is missing from our definition? Any operations, any focus that you think it's integral to really achieve that global health, that health and wellness for all, no matter where in the world you are? Is anything missing from that definition? Please help us to, you know, either a phrase or a short answer. Please help us to redefine this. Yeah, so place it anywhere on the whiteboard, if you will. Are we able to see the whiteboard? Right, so the easiest way is to select text and then write.
Oh.
Okay, I see that several people are maybe writing. So are we able to see that, Richard, the whiteboard, or is it just
I
me?
am able to see the whiteboard, yes.
Okay.
Yeah, I'm able to see the whiteboard. And I think, yes, it's possible to write by hand, it seems like, or, well, let me see.
Yeah, so you can either select the pen or you can select the text,
Right,
and then write anywhere on the board.
right.
Please help us to interactively create this board. We are really looking for your input here. Don't be shy. We rely on your engagement. Okay. I see lots of names of floating around.
Yeah.
Okay, good. Okay. Good. Thank you so much. So we will let this go for the next 2 minutes. So please help us with the input. And we will share the results after our session, along with the recording session. Thank you. Okay, so please, 1 more minute. So again, please help us to define if you see anything missing from the current definition, any crucial area in global health operations.
Anna, can you paste the definitions or show them the definitions in the chat? Someone said that in the quick Q&A.
Oh, you cannot see the presentation at this point. Okay.
Mm-hmm.
Okay. Okay, so one more minute before we move forward. The definitions are in the chat. Please, if you didn't have a chance to comment on the whiteboard, please include that in the chat. We really want to know your opinion and hear your perspective. Okay, so at this time we will close the whiteboard, but please continue to comment in the chat, and let's move on with our presentation. Okay. Okay. Are we able to see this? Okay. So do we think that we can move on right away, Richard?
I think so, yeah. I think so. It was a quick,
yeah, it was a quick
good connection, and the whiteboard worked really well. Thank you for sharing that. I think instead of taking the break here, everyone, we can move on to part number 2 of our conversation and presentation today, which I'll lead, and then we'll take a break after that before we have a keynote address or speaker guest coming after this section. So I'll lead this conversation to global health operations, products and deliverables. With me here, Sri, I hope you're on and can participate and contribute, as well as Abara. As I go through this discussion, please let me know whether I'm covering everything. I think this is to our members, to new people who are joining us today. And also persons who perhaps either were not able to attend the conference in the spring this year in Washington, D.C., the CUGH conference. So I'll talk about the feedback that we received from the satellite session that we had during the spring conference 2023, as well as the panel that we held during that time. And then the deliverables specifically that the committee has been working on over the years. Just a bit of detail in my engagement with the committee is that I am currently a co-chair with Anna here. I was also a co-chair in the previous section of 2 years before our current 2-year time or term. And I've been a member of this committee for several years prior to that. So I've witnessed growth. We've seen changes in the international order or the manner in which people travel today. You know, committee started with CUGH several years back. And then, of course, there are huge effects with regard to, operations for global health across our partner institutions and particularly in context of COVID-19. But the world has changed quite substantially over the years since we've had this Global Health Operations Committee. So let's, advance the slide, Anna. I think I'll be calling you to do that, please. So yeah, so we had 2 satellites. We had a satellite session. We had a panel. This is part of the satellite panel event that we had. As you can see here, the focus was current topics in global health operations, challenges, opportunities for an equitable and sustainable future. The conference, the CUGH conference of this year, which is 2023, was focusing on related aspects to climate, antimicrobial resistance, and equity and justice. So every year, the conference, the CUGH conference focuses on a specific theme. We started talking about global cooperation and global operations in context of the next conference, which is 2024, to which this meeting here will contribute, and we have planned a panel also for 2024. So this satellite session that we had, as you can see, had 2 parts to it. There was the section where the white paper that has been ongoing as part of the project of our committee was shared and presented, and specifically the white paper was collecting views from our low and middle income partners, particularly in context of how the engagement is going with high income institutions. And so that product was presented during that time. There was also a survey that was also presented. I will overview that. We'll also talk about the feedback we received from the participants of that meeting. And then we had this small group discussion on priorities for global health operations. As you can see here, our focus was on a memorandum of understanding, workforce development, barriers to travel. So we got to hear a lot from the people who attended the satellite session. So let's move on to the next slide, Anna. So this section here will be presented. Is that correct, Anna? I think we have one of your colleagues going through this, you said?
One of our committee members, Carrie, will take this on.
Okay, thank you. So Carrie, welcome.
Welcome, thank you. My name is Carrie Brossard-Stoos, and I am at Ithaca College in New York in the United States. And I'm just going to start taking us through the survey data. So can you please advance the slide? So as Dr. Wamai already introduced the mission, I'll just talk about a little bit about the goals of this survey. It was basically to get a better understanding of what organizational structures that our partnerships are working with and in, what are their support systems and funding strategies, how the structures are centered and governed, just to get a better idea of that. And this was delivered using a Qualtrics survey between March 2022 to February 2023. It was notified through the CUGH member institutions using a newsletter, through direct emails, direct contacts, and then just basically a snowball sample of institutions. The timeline of the survey was developed in the fall of 2021. It was pilot tested in 2022. And then, as we mentioned, it was delivered in 2022. And then spring 2023, we then went through the data analysis. So next slide, please. Oops. I think one back. Yes. So as you can see here, in the right-hand side, you see the percentages and the raw data of the numbers of respondents. We had 44 total respondents. And then on the left-hand side, you can see the primary geographic location based on those World Bank regions that you saw in the poll earlier. And similarly reflected also the types of academic institutions. We see a greatest percentage at 33 respondents through academic institutions, similarly to the respondents that you just saw in the poll earlier. But going back to the first block, the majority of the respondents were in North America, but we did have some success getting some respondents from other regions, World Bank regions, as you can see, 18.2% in Sub-Saharan Africa, and then respectively 2.3% for all the remaining regions. The primary focus areas were mainly education and training, also reflecting the academics that we saw earlier. So next slide, please. And then moving on to the second questions in the surveys were based on governance and what are the primary governance structures in the institutions. And as you can see here, we had 14 respondents that were in medical schools, 8 for health sciences colleges, 6 for Office of President, Provost, Vice Chancellor, and 6 for other. And one of the surprising survey results here was that we had student and student groups as a pretty significantly sizable response, as you can see in this bar graph here. So next slide, please. And then we moved on to services. We asked about human resources, financial services, legal and contracting, travel and risk management, communications, development, and other services. And you can see where are these offered and at what level are they offered. And in the blue squares here, we have department and programs. And then parceled out in gray is through a center or institute. In light blue, we have central administration, and then in the dark blue or black is other structure. And so I think it's important to see the sizable amount in central administration, but this just gives us a better understanding of the diversity of where these services are offered. Then we moved over to financing. Financing seemed to be a significant topic, mainly understanding that a lot of the respondents mentioned that there is a problem with funding and that many programs are underfunded and that they would wish to have more funding. But just to give us a better understanding of where funding is coming from, 35% is through gifts or funds, and 28% is through institutional support. So about half of the funding is through gifts and funds and institutional support. And it's important to recognize that we need to really understand better and figure out more sustainable funding sources and try to increase revenue across the board. Okay, thank you. Next up, next slide. And then we go into what is viewed as the largest risk for or operational challenge at respondents' universities related to global operations. And you can see this overlapping Venn diagram of where the challenges lie. We have issues with global safety and security. And because of the timing, as mentioned earlier, COVID-19 really was a significant challenge just based on the timing, and it still has some significant impacts and lasting effects. But aside from COVID-19, we also saw that global health and was not a strategic or institutional priority. Again, the lack of sustained funding that we mentioned in the previous slide, and lack of operational support for global health activities, bureaucracy, or restrictions. Next slide, please. And so as part of question 7, this was what is, as we consider developing increased communication or some sort of structured platform for networking through CUGH. So indicating, we asked if university or if the respondents could indicate 2 to 3 resources that would be most helpful or most useful. And these were some of the top 3 choices: searchable database for networking and collaborations to really build out partnerships and using templates for that, and shareable resources. The second one was resources for international human resources, contracting, guidance, basically for getting better ideas for hiring and pay and taxes for across institutions and across geographic locations, as well as procurement. And then finally, providing a forum for discussion of international safety issues. Next slide, please. And so in order to try to build these platforms, we wanted to know what are the best strategies for communication or sharing these resources. And as you can see, the majority of the respondents really said either Microsoft Teams at 32.4% or Google Drive at 29.4%. But other resources included Canvas, Slack, or some other method, either OneDrive, Zoom, Box, or other resources. Next slide, please. And then additionally, what types of online communication platforms does your institution prefer and regularly use? And again, it seems that there is quite a majority of respondents that are using Zoom and email primarily as the main uses of communication. And we also see though Teams, WhatsApp, Skype, Google Meet, and other methods, landline phone or other. And so that's actually interesting because we are currently using Zoom right now to share this satellite site. So we are currently using one of the majority preferred platforms. So next slide, please. So basically, to summarize from this survey, we had some clear takeaways is that we need a clear definition of global health operations, and hopefully we're getting closer to that as with the whiteboard and some of the work that has been done in this satellite session today already. We also have operations are occurring across all administrative levels. So there is diversity amongst how the operations are occurring. And this presents areas for challenges and for growth to understand how can we provide support for that. Also, funding is coming mainly from institution itself or potentially from gifts. And there needs to be, and along with that is that many respondents said even with this funding that they still feel underfunded. And so there is a need for support to help seek sustainable funding, especially with external grants. And also a need for a shared communication platform. And our existing key resources, which you will hear about today, is the travel toolkit that this subcommittee has been working on, and also a capacity building platform. You just heard about the white paper. And then additionally, there's still needs of searchable global health specific database for funding, as we keep mentioning. Funding seems to be the buzzword that we saw. And then additionally, seminars, workshops, guides on global health operations management. So this is across all services that we mentioned previously. And then the possible products, we already know about the toolkit for travel, but additional products that we want to have come out of this would be additional webinars, checklists, databases, and the white paper that was previously mentioned. Next slide, please. So we do recognize that there were some limitations to this survey, as we mentioned, that the majority of the respondents were from North America, and specifically majority were from the United States. And again, there was an overabundance of the academic institutions being represented in the sample. So we do need to acknowledge that and take that information into account when we're looking at these data here. Additionally, the survey was deployed during COVID-19 at the height of the pandemic. And so, again, this may have skewed some of the data. Next slide, please. So I want to acknowledge we are first of all, the survey respondents, because we know that we wouldn't have these data without the respondents, but also Anna Halova and Allison Lofthouse for synthesizing some of these data and working on the survey. Also Keith Partika at the University of Illinois and the CUGH Global Health Operations Committee and Leadership, and also AfriHealth. Thank you. And I will then pass this back to Dr. Halova for moving on to the next steps.
Thank you so much, Kerry, for presenting our results. I would like to pass on the presentation back to Richard.
Unmuted, yeah. Yeah, thank you. Thank you very much, Anna. I think we would like to open this session with some discussion. Perhaps there are questions that have arisen after Carrie's presentation. So will be an open, few minutes that we can ask specific questions to Carrie, or questions that people would like to discuss further. The survey found quite very useful information related to databases for funding, as well as communication tools or how we may communicate better. So I think it'll be very valuable to hear from people what is the next step that we can do, how far or how much more could the committee do, what could CUGH do? What is the responsibility of CUGH? What the committee can propose, advocate for, and so on and so forth. So if anyone has a question, would be good to raise it here. I'm curious, Carrie, on one of the slides which shows, the tools or the systems that institutions use to communicate. And Zoom and email seem to be quite high. Teams was a little bit lower, although members did indicate that they would appreciate communicating through Teams. That came up on top in terms of choices of medium of communication, while Zoom seemed to be more frequently used, as well as email. And I think also on the slide that was showing email and Zoom as high use, there was only about 30%. But I suppose that didn't mean that only 30% of the respondents were using email and others were not using email. I suppose that's not the case. Do you know how that is sorted in the data?
Yeah, so that's a really good question. Thank you for that question. I would have to go back to the raw data just to look, but I believe what ended up happening was individuals responded as preference.
Mm-hmm.
And so some of it may have been ranked. So, even though they're responding as email as 30%, potentially more people are using email, but they didn't use that as their first choice, potentially. But I would have to go back and look at that raw data.
Okay. Thank you. Any other thoughts or questions people may have? Mm-hmm. Anna, to you, and I think Dalal is also here. We may want to have a conversation about how we may move forward on some of those aspects with regard to maybe better ways to create communication channels or communicate information, or whether we have another way to maybe develop a database that could be available on our committee website. So, but thank you very much. Let me move on to the next section or the next item with the LMIC partnership white paper. This is work that Abara, you have done a lot with Jason, and I invite you to maybe make a brief remark about this work. Please, Abara.
Yeah, thank you very much, Richard, and thank you, Anna, and welcome all of you to this conversations. The LMIC partnership white paper actually was a product of a questionnaire that was distributed a few years ago, but the input was more or less limited to things coming from sub-Saharan Africa, and it pointed out a number of limitations and challenges between North and South organizations in global health. And what came out of it is that more programs being established in low middle income universities. Many attempts to build relationships and partnerships are rather clumsy and lopsided. Most global health operation guidelines focus on high-income institutions. But through this survey, we could hear and listen to more or less loud pleading from low and middle income countries that there has to be some synergy in working together, building bridges, closing out disparities between the haves and the have-nots, between the North and the South, and creating some level of equity in terms of operational tasks, research, and ownership of research and outcomes. So there are limitations we find even in the study because most of the information tended to come from Sub-Saharan Africa. But we think that going forward, we should be able to repeat this survey questionnaire, engaging other parts of the world, like Latin America, the Caribbean, Southeast Asia, Europe, or even North America, because there are areas of disparities. But this is something in the works. The white paper is out there for us to look at and for people to continue to make contribution. Mm. But what we are hoping would happen in the next year is for us to enlarge and get more people saying what they want us to do as an operational committee and what they really want global health operations to be in the whole world, not just North America, not just Europe, but engaging all LMICs and everywhere. I'll keep quiet and take some questions.
Yeah, thank you, Abara. Anna, could you see the next slide? So yes, I think Abara has well introduced the white paper, the methods that were used, the sample size is also included here. I think it would be good to see, Anna, maybe one of the next couple of slides. As you can see, there's this partnership framework that was proposed. Abara, thank you very much for making your brief overview of the process, as well as the partners who participated in the survey and the findings that we have. As everybody can see here, they have to do with how we build relationships, the type of commitments we make, the objectives of these relationships, how we communicate, and what needs to be done with regard to capacity building and so on and so forth. And with regard to capacity, funding, comes up again in terms of how resources are distributed, are used, are resourced, and the need to access quality and build impactful relationships. So we have some good results, I think, Abara, from the work you did, and certainly hearing voices from the partners who contributed is valuable. If we have other partners from Latin America or the Middle East, South and Southeast Asia, and other regions like that whose voices are not represented and are different from the voices we have from Sub-Saharan Africa, we can have a more comprehensive picture of how our partners in the Southern Hemisphere feel in this regard. So, Anna, can you see the next slide? Yeah, so Abara, when you had this discussion at the in the satellite in the spring, these are some feedback that you received. So do you want to digest some of them?
Yeah, these are very important issues, and part of what we believe this should do is going forward to one, carry out an additional questionnaire survey engaging all partners around the world, Sub-Saharan Africa, Latin America, Southeast Asia, Northeast Asia, Europe, and everywhere, so we can get a more comprehensive information of what is going on. We believe there are inequities around the access to information. The librarians want to know how they can help to advocate with vendors and open access and open science. And these are things that we need to work on. We have to now complete the white paper, get it published, and then do the new sampling. And this is where we want all participants in this discussion to bring out their ideas, participate in the next sample size we're going to be developing, and contribute their views, because that will give us a more comprehensive information to help us in building and growing partnerships and being culturally sensitive to how we carry out global health operations around the world.
Thank you, Abara. There's a question here from Tsisi Masvavure, and you ask a good question. Now, I've just commented, the white paper is not yet published, as Abara has indicated here. It is something of one of the committees that we have within CUGH, Global Health Operations Committee, to finalize, and then it can be shared, deposited on the website, the link that I've shared here with everyone. But I wonder this question here about CUGH dominated by medical schools and health sciences, social sciences, representation. I'm not quite sure about that, but that's a good question, Tsisi, and perhaps Dalal here on the call. You know, I don't know whether we have somewhere within CUGH website that someone may be able to see the membership institution, but the split between medical schools, schools of health sciences, social sciences, and so on and so forth. Maybe that is something that could be done so that we have a good vision of the institutional makeup of CUGH. Thank you. But Sisi, I am not in the School of Public Health. I'm not in the medical school. I'm in the College of Social Sciences and Humanities. Yeah, thank you.
Yeah, no, to add to that, I'm the other co-chair of the committee, and I'm also a social behavioral scientist in the School of Public Health at my university. So I guess we are getting that voice in.
Yeah.
Which is a good thing. We want everyone engaged because health is for us all. And that's the goal, interdisciplinary, multidisciplinary. We want everybody on board, bringing in their own views for a better health, better planetary health.
Right. Yeah. Let's move on to the next item, Anna. Yeah. So CUGH has also, our committee has also been developing and building a travel toolkit. This toolkit has been in the works for many years. I would think probably 8 years or so. So a work that we started probably around 2016 or 17, thereabout. And then, there is work that has been done. The travel toolkit is itself on the website. The link that I've shared with everybody, you can be able to access and download the toolkit over there. The effort has been led by Chris, one of our longtime members of this committee, who was also a co-chair of this committee as when I joined the committee. So the toolkit can be seen as an important, contribution to help us understand issues and challenges and opportunities related to travel, because travel is a very important component of global health. In context of COVID-19, of course, there was more limited travel. And that was a focus of our conversation for the 2022 CUGH meeting that happened online. So the toolkit is there, it's online, it's a resource, it can assist members, new members, people who are unfamiliar, perhaps looking for questions that may be beneficial, and it is based on, it's based on a general collection of documentation and materials, and it is not a cast in stone tool, because travel changes all the time. Patterns of travel changes, laws emerge, different restrictions may come as given the geopolitical environment in which we live in today. And it needs to be continuously updated, but it can be beneficial to members. The next slide, Anna. So these are the sections of the toolkit. So just very briefly to overview, you have a section 1, pre-deployment. What do people need to know with regard to these topics? Health, safety, for students, for faculty, issues that one should be concerned or at least take account of when planning travel. Security is important in the place where people are going to, health considerations. For U.S. citizens, there's always this proposal or recommendation that people register in a database that is available for persons in the U.S. It is also the case in my institute, my university here in Boston. We also have a central site where faculty and students traveling abroad also register within in the university, so that it is known where people are. So you can see there are many items here. Section B is during deployment, what people face when you're on the ground in a new place, in a new environment, which is maybe unfamiliar, or that you're going to a new setting and meeting new people, new cultural contexts that emerge, travel within the country, communication. And you can see there's also a section C here that is post-deployment. What there needs to be, what people could do to improve or enhance their experience after the travel. So it is a generally, a thick document. It has, entries on all of these topics, and it could be a valuable use for members. So just to be aware, and especially if this is new to you, you might want to download it. Perhaps a recommendation could be that if you're, an institutional administrator within your institution that deals with global health, travel, and operations, it could be a tool that could be available for students and faculty, and can be made locally available within your institution as an additional document to other preparations that travel requires to make. The next slide, Anna. And if there's any other feedback beyond the feedback that we received in the satellite for this in the spring, you can see some of the comments that were given here by people. Now, I know, Abara, you were not involved in this toolkit travel itself. I wasn't engaged in it in depth, unlike Chris. I don't know if Chris is here, but yeah, we'll leave it there for a bit to hear any feedback from anyone. or any additional comment with regard to this toolkit?
Yeah, this is Emmanuel Abara, during the discussions there, particularly I was involved with the low income, middle income group. We found that there was quite a disparity in the way students who are coming from the low income group to the Northern Hemisphere are treated. And one of the suggestions on the table was that there has to be some advocacy system whereby universities or organizations sending their learners to various parts of the world create some awareness among the policymakers or political leaders around the world, so that travel restrictions or travel is made a little bit easier for particularly learners who are innocent, enthusiastic, and just want to do what they want to do. And I think this is something we consider that the CUGH should look into and create this type of advocacy group and system to facilitate travels, not just from the low-income countries to the high-income countries, but even within the low-income countries, there could be such difficulties. I'll stop there.
Yeah, thank you, Abara. So we invite your contribution to this conversation. The toolkit is already on the website. As we said, it's a living document, can be updated. There are some limitations with regard to that. For example, we know that the developers of this toolkit are based largely here in the US. And so, of course, there are perspectives that may have been missed from other members from low and middle income countries. It is also probably geared towards health concerns and consideration and security concerns for people who are traveling from the US, given the focus there. So there is need to expand resources for travel beyond those that may be found in US settings or for US travelers. So there could be also other questions that perhaps other travelers coming from, for example, people traveling from Southeast Asia or South America or the Middle East going coming up into North America or Europe, or going to other regions in the world that may not have been covered or captured in the travel toolkit. So it may need additional content for each of these areas, pre-deployment, during deployment, post-deployment. And so it is open for contribution and participation by other members. And so it would be valuable to have any additional feedback that may come there. Yeah, so that's it with this Global Health Travel Toolkit. Anna, can we move on to the next section? Yeah, so we had anticipated to have a short 10-minute conversation in small groups. So Anna, I'll give it back to you to distribute this group. We're not too many of us, so it could be that we split into smaller groups, get to know who is on the group, and just spend a few minutes sharing experiences in our context. All right. That session ended kind of abruptly, Anna, but I think we got some good conversations going on there. I picked up a couple of challenges from our room, and I'll give it back to you, Anna.
Well, thank you, everybody, once again. So let's have a quick summary, if you will. We ended up having 2 rooms that were active, so we consolidated into 2 rooms. So if I can please ask one of the representatives from each room to quickly summarize the discussions and major takeaways, that would be great.
So, Abara, may I invite you, because, or at least in the room that we were with, Shahanaz was with us, Brittany, we have a number of other people, and Abara was making a comment, and we were discussing financial and contractual issues related to global health operations. Shahanaz shared with us a practical challenge in building and developing and pursuing a partnership with Bangladesh and Ethiopia, and related to administrative aspects and other areas. And then Abara was sharing a possible pathway of how maybe new type of relationship could be built by developing and leveraging and community partners. So Abara, do you want to complete your thoughts? Yes.
Yes. Thank you for the opportunity, because I think sometimes people in academic institutions, we follow some specific rules and guidelines. Those guidelines are great to have, but when you are looking at engaging multicultural, ethno-cultural groups, we have to be what I consider ethno-cultural sensitive, because sometimes the way you write things on paper are understood differently in different situations. And what I've found very beneficial is what I call private partner-public relationships, building that relationship, knowing where to touch to get things to happen. Mm-hmm. Sometimes as academicians, we know it all. We know how to write it on paper, all the theory, but in terms of building that relationship that will make our things work, we need to reach out to others. Mm. Sometimes reaching out to community groups like a Rotary Club, a non-governmental organization, or even grassroots community leaders who are sometimes well-educated and very well-meaning. So my thought and contribution is for us to reach out. Don't enclose yourself to your academic relationships. It's good to maintain them, but reach out to your community. There might be people who have things to do to help you, or people who are in a position to leverage things that should happen positively for you. I'll stop there. Mm-hmm.
Yeah, thank you. Thank you, Abara. I think too, in context of my experience and Shahanaz, to maybe a take-home message could be, and for all of us, that this inter-institutional collaboration across academic institutions could be a bit challenging. I have seen models where, like the Empath model, which is a strong collaboration across multiple institutions in Kenya and Ghana, and also in North America, but also other approaches that use nonprofits or non-government organizations. In my experience, I have created one NGO, actually registered in Kenya, just because bureaucratic challenges with an institution here in North America makes it very difficult to then leverage resources from outside the US context into, let's say, Europe and elsewhere. So that then it becomes a bit more beneficial and nimble for program purposes, for research, to work through a nonprofit mechanism that is an offshoot of your partnership between academic institutions. Okay. Anna, back to you. I think that was in the conversation we were having at the contracts and financing room. I don't know which other room people got to meet.
Yeah, so there was a rich discussion going on in room number four, which was related to technologies. Could I ask one of the people who were in that room the whole time to summarize for us the major key points, please?
So I wasn't in there the whole time, but so the issues we discussed, or just the ideas we discussed, was like differentiating the difference between lack of resources and then low and middle income countries, because I brought up how like maybe technology in these low and middle income countries might not be a priority for these places. So I guess choosing what to prioritize. But then we also had someone discuss somewhere where it was implemented and it worked really well. And he told us that people can thrive off of very little. So things such as like he has Starlink that helps with an internet and solar power and like natural resources for electricity, where in other places like that's something people struggle with. So having things such as like telehealth would be like I thought too, a last step as well. Like it's not something we would get to now, but the importance of it is very prominent. And there are ways to achieve it, because he was discussing how they did achieve it and the importance and also the benefits of it as well.
That was David Vanderpool who said that. And based on his 13 years of experience in Haiti, talking about Starlink and electricity, yes. And he said that having the technology was transforming. It was disruptive in a positive way, transformation that was allowing them to attract more funding and enhance the quality of healthcare for all, and also training and education. So yes, I mean the idea is to strive for that if it's possible, but of course, as you just said, no, it's not easy. I'm Brian Rudkin, by the way.
Thank you, Brian.
Yeah, that is an amazing discussion, and I'm jumping a little bit ahead of time, but for our panel discussion that will be going on at CUGH 2024, we will be focusing the discussion on technologies and how it can be a solution, solution the challenges related to technologies in global health operations. So again, this will be a discussion, the panel that will be taking place at CUGH 2024 in LA in March 2024.
I suggest you invite David. He's a very good speaker, and he has an excellent experience and long-term experience in the field.
Yeah, I just jotted his name down before you said that. Yes, thank you so much. So if we can reach out to you, David, that would be wonderful.
Absolutely.
Thank you.
Yeah, thank you, David. Anna, we are about time to have our NIH speaker. That's correct?
That's correct. So I think we should probably let people to have 5 minutes break.
That's right.
Before we go, as you can see, this discussion can go on for many hours, still minutes, and we are really pleased that so many people are attending our session. So let's take a 5 minutes break before we go to the NIH session. Thank you so much for Bruce joining us today. So in 5 minutes, which will be 10 Central Time, 11 Eastern US time.
Yeah.
Thank you. Please don't leave us. Just take a brief break and join us back for the NIH.
5 minutes. Yeah. Thank you. Yeah, I think, hi, Bruce, Richard Wamai here. I'm in Boston. I'm a co-chair of this committee, CUGH committee with Anna. I've seen email communication, and I think right on time. I think we can get everybody back on and have you take us through your presentation. We suggest that people can post questions on the chat window and then we have an opportunity for a Q&A with you towards the end of your presentation. So welcome, Bruce. I'll not introduce you beyond that, but you could, I mean, as you come on board, if you want to mention anything particularly about the work that you do, but we are very happy to have you here. Thank you.
Thank you very much. Hi, my name is Bruce Buttram. I'm the Chief Grants Management Officer at Fogarty International Center at NIH. I've been the Chief GMO for about 22 years, and I have with me Vicki Tran, who is a Grants Management Specialist. She's been with us for a couple years and is doing a wonderful job for us. We manage all the grants policy and administration. We work very tightly with the program officers, so it's kind of a one-to-one ratio with us. So we have one program officer, one grants person, and we manage the grants together as a team. So it's not just one person doing it. And it also provides more accountability because the grants staff are the only people able to make changes to a grant. In other words, program officers can't authorize changes to grants, only the grant staff can. We'll go over the agenda real quick, the table of contents. Vicki's going to do some policy updates. There's a few FAQs that I'll present. We'll do an open Q&A session because we wanted to see if people wanted to ask questions. And then if we don't have enough questions, we also have some additional slides that we put in under the tips, useful information for submitting grants to NIH. So with that said, I'm going to switch to Vicki, and she can go over the policy updates.
Good morning. So first and foremost with the policy updates is the most recent policy, I believe, of big concern is the NIH final updated policy guidance for subaward and consortium written agreements effective January 1st, 2024. Next slide, please. So in short, this policy says effective January 1st, 2024, written agreements for foreign subawards must contain a provision requiring foreign subrecipients to provide access to copies of all lab notebooks, all data, and all documentation that supports the research outcomes as described in the progress report to the primary recipient with a frequency of no less than once per year, in alignment with the timing requirements for the RPPR submission. Grant recipients will need to be compliant with this updated policy guidance no later than March 2nd, 2024. Now, at the bottom of the slide, we have included links to the NIH subaward page, as well as the common FAQs that the NIH Opera has received thus far. And then we'll also, in the next coming slides, go over these FAQs with you. So the first FAQ is, what does the NIH policy guidance mean for foreign subawards established before January 1st, 2024? In short, NIH expects recipients to update existing foreign subawards if needed within 60 days of the effective date to address the requirements. So if you need to update your subaward agreement between now and January 1st, we encourage you to include this provision before then to prevent added extra work after the first of the year. Okay. Next question is, if a recipient organization has a large number of foreign subaward agreements to comply with this updated policy, can they request an extension? And the short answer is yes. You can extend request for an extension by contacting Opera at the grantspolicy@nih.gov email. What is the prime recipient responsible for once they receive documentation supporting research outcomes from the foreign subrecipients? The prime recipient should continue to review all subaward documentation to confirm that the performance outcomes that are reported in the RPPR are accurate, complete, and properly reflect the programmatic goals as stated in the RPPR. And what is the expectations for retention of the supporting documentation provided by the foreign subrecipients to the prime? And would this information ever need to be provided to the NIH? In short, as outlined per the NIH Grants Policy Statement, Chapter 8.4.2, the record retention and access, recipients must retain the records pertinent to the entire competitive segment for 3 years from the date the final federal financial report, the FFR, is submitted to the NIH. As also outlined in this chapter, recipients must provide access to NIH upon request. And how does this policy guidance affect NIH foreign prime recipients? This policy requirement applies to all subaward arrangements. This latest policy guidance specifically calls out domestic prime recipients who are responsible for overseeing foreign recipients, as this was the focus of an Office of Inspector General's audit findings. There have been lots of concerns expressed that this policy guidance unfairly singles out foreign subawardees and potentially undermines NIH's efforts towards diversity, equity, and inclusion and reaching underserved communities. Both the Office of Inspector General and the General Accounting Office audits of NIH explicitly called out foreign subrecipients, and one called out specifically the unique challenges that domestic prime recipients face when dealing with foreign subrecipients. We, the NIH, understand that foreign subrecipients are diverse and that a number of them may have less resources than others. We are hoping that by making it clear that using commonly used digital platforms will help enable everybody to be compliant with this long-standing regulatory requirement. The general principle is compliance with terms and conditions of award and access to materials that support a progress report apply to all. So then what happens if a foreign organization is subject to local laws or policies which conflict with NIH requirements for making copies of documentation that supports research outcomes available to the domestic prime institution? There are 3 key points. The first, recipients, prime and subrecipients, have to be compliant with terms and conditions of award. The prime recipients are responsible to the NIH, and then those terms flow down to the subrecipient. The NIH expects that all recipients, including subrecipients, will follow all applicable state and local laws. If there is a concern about whether or not local laws or rules or regulations may affect ability to be compliant with terms and conditions of award, the recipient or subrecipient should consult with their general counsel on the facts of the specific situation. NIH's data sharing policy explicitly does not require the sharing of lab notebooks. Can you discuss the difference between policies and oversight of foreign subawards and data sharing? So the 2 policies are distinct between data sharing and the foreign subawards. Data sharing is about what we expect grant recipients to share with the public, whereas the NIH requirement for foreign subawardees to provide the prime awardee with access to notebooks and other documentation that support research outcomes reported in the RPPR has to do with what information collaborators must share with each other to support award, oversight, and compliance. So one is sharing with the public, the other one is compliance. Next slide. The next policy we will move forward with is about the data management and sharing plan and policy. The most recent that just went into effect October 12th of 2023 is that prior approval requests must be submitted in the ERA Commons prior approval module for any changes to the DMS sharing plan. The other two policies reflect on the updated forms to the data and management sharing plans, which we will highlight in the next slide, please. So in short, the changes to the data management and sharing plan is pretty much formalizing what the plan should contain. Trying to make the information being shared and reported is much more consistent and reflects the element that we are looking for. So you can see between the old policy from 2003 and the new policy implemented in 2023, it's a lot more specific in the level of detail we are looking for. Next slide. And should you need additional guidance, information about what NIH is looking for in the data management and sharing policy, the plan, or any FAQs, we included links here. There is a wealth of FAQs on this policy, should you have any questions about them. And lastly, for policy updates is the NIH response to registration issues involving SAM.gov. Effective July 14, 2023, the previous exemption to the late application policy involving SAM registration issues have been revoked. So in short, there are no excuses for late applications due to late SAM registrations. So exactly what does this mean? Next slide. A yearly renewal with SAM is required to keep your grants.gov registration active. This registration must always be active. The NIH policy is that the expiration date cannot be within 30 days of the budget start date. So for example, if your grant has a start date of December 1st, you cannot have your SAM registration expire anytime before December 31st. If you are experiencing any difficulties with SAM, please contact the Federal Service Desk through sam.gov as early as possible. You will want to first submit an electronic help desk ticket. And if you will want to call that help desk ticket. You only want to create one help desk ticket. Do not create multiple help desk tickets, as it will not speed up the process to assist with your difficulties. In short, if your registration is not compliant, not active, not up to date, we, the NIH, cannot issue any funds, cannot make any awards to your institution.
Thank you, Vicki. Well, by the way, we will be looking at the chat room for questions in a minute, and then when we get to the open session, we'll discuss all those. And like I said, if we have enough time, if there's not enough questions, we have actually additional slides. Okay, so how should domestic grants pay for foreign consortiums or subcontracts? Many foreign institutions have unique fiscal needs and or may not have the infrastructure to pay award costs prior to receiving a grant funds. Therefore, it might be reasonable for a U.S. grantee institution with a foreign consortium to provide the foreign institution quarterly advances of funds or arrange a reasonable payment schedule to accomplish the goals of the NIH grant. As you know, that domestic institutions, they can draw down the money as needed. They do not have to do cost reimbursement. Unfortunately, sometimes we hear that grantees, U.S. grantees or domestic grantees are doing cost reimbursement or these types of things. That is not a requirement. We advance U.S. grantees money ahead of time to cover costs, and therefore it might be reasonable to do that for the foreign institution. It really is up to the domestic institution to make that decision. Ultimately, the payment arrangements are subject to the grantee's institutional policies and should be clearly defined in the consortium agreement. Okay. Foreign travel. Do I have to use certain airlines when staff travel on an NIH grant? Yes, grantees must comply with the requirement that a U.S. flag air carrier be used to the maximum extent possible when commercial air transportation means travel between the U.S. and a foreign country or between foreign countries. This requirement shall not be influenced by factors of cost, convenience, or personal travel preference. And, you know, that it is what it says there, that if you have, in the sense that you have a U.S. carrier and it's much more expensive than maybe a local carrier, you do have to use the U.S. carrier. In all cases, travel costs are limited, though, to those allowed by formal organizational policy. In the case of air travel, the lowest reasonable commercial airfares must be used. And I put a link into the FAQ that Fogarty has on foreign travel, and it gives you the Fly America documentation. What are the exceptions to the Fly America Act requirements when travel solely outside the U.S. and a U.S. flag carrier provides service between my origin and my destination? You must always use a U.S. Flag carrier for such travel unless when compared to using a foreign air carrier, such things would happen. An increase in the number of aircraft changes you must make en route by 2 or more. It would extend your travel time by 6 hours or more, or it would require a connecting time of 4 hours or more at an overseas interchange point. Mailing addresses and contact information. All mailing physical addresses and contact information must be current and correct and identical across the systems. We've experienced this last year where some of the systems like PMS, it must have put in an edit check. In other words, what I'm trying to tell you is that all the systems have to have the same information. The ERA Commons, the SAM, the NCAGE, PMS, and the EIN number, which is a NIH-generated number, must be the same in all systems. And when it's not, it's caused havoc because it doesn't allow us to provide money to the grantee. And so we've had to work with grantees to try to fix them across the system. We have no power to do that. It's up to the grantee. So if you have a situation where you're renewing your SAM or your NCAGE or having problems, you have to realize that all this information must be exactly the same. You can't have, something like Cape Town, hospital or Cape Town HOSP period. And have that a difference in the system, because that will block the system. They actually literally have to be identical. So I'm asking all the grantees out there to realize that they need to do this and to relay that information to your colleagues. Corrections must be made through the respective systems, help desk. So you need to do a help desk ticket or fix it in the system. Misaligned information will cause delays with the award and possibly not access to funds. We've actually had situations where people have been delayed 10, 12 months in trying to get access to their funds because they can't fix the systems. Also, cost considerations, a reminder, when you're looking at costs, they have to be allocable to a grant. In other words, you have to be able to allocate them to that project. They have to be allowable by the cost principles. They need to be reasonable in the sense, you can't have something that's ridiculous, like a laptop for $20,000, consistently applied. So it's also important for your institutions to have consistent policies in place so you can have them applied across your institution regarding policies. Okay, so I want to now go to the Q&A session. We can potentially have people call in and talk. There is one chat. I'll read that. What can an LMIC institution do to implement a new policy? What if their government and institution is not allowing sites to share lab data and other documentation? We did address some of those. And if we have not addressed them in the FAQs, then you do need to check with your legal staff at your institution and see what the problem is. And if there is a problem, then you'll have to reach out to the institute at NIH that's funding your grant, or potentially OPERA, which is the office in the office of the director that was allowing delays and things, to discuss this. There's another question here. Is NIH considering increasing F&A for foreign institution? So giving a little history about this is that back prior to 2001, there was no money provided for F&A for foreign institutions. Then in the early 2000s, the NIH budget got doubled and they allowed 8% F&A for foreign institutions. And that was in line with the career grants that we provide in domestically and internationally, and also training grants all over the U.S. There has been a discussion about F&A rates for foreign institutions getting more money. The problem is that it also is a significant amount of money in the NIH budget, and the fact that these other mechanisms at NIH, which are providing funds to U.S. institutions, are only providing 8%. So as it stands right now, there is no possibility at this moment, but you never know what can happen in the future. Does anybody else have any questions they want to provide in the chat?
Yeah, please feel free to ask any questions that you might have. I know behind the scenes there are a lot of people concerned about the new policy and how it will be implemented, both from the US institutions and LMIC institutions or foreign institutions.
Question, Anna.
Mm-hmm. Yes. Please go ahead, Dr.
Now, Mr. Broughton, how easy, let me phrase it differently. How can someone who is not a U.S. citizen or doesn't work in U.S. be able to obtain NIH grants?
Okay, so if you're a person in another country, you have to follow the procedures. Actually, there is a website on the NIH website that talks about how to apply for a grant, and then there's a specific section on how to apply for that gives you tips and ways to help you if you're a foreign institution. A person normally is associated with an institution, and then the institution applies for the grant. Now, grants are made out to institutions, not people. So that's how it normally works. So if you're associated with an institution, or you could seek out an institution, and I would suggest that you seek out an institution that has maybe gotten NIH support, whether through a subcontract or directly, because they obviously have more of the infrastructure to apply for an NIH grant.
Thank you.
Does that answer your question?
Yes.
Okay, thank you. Also, by the way, On the Fogarty website, we also have some resources that for people trying to get money that are not looking for NIH money. We have a piece on our website or links to give you other opportunities to provide funds. So I would suggest you go to the Fogarty FIC website at NIH and look at our other useful, helpful tips on finding other sources of funds.
Hi.
The other question, I guess, because it has to be an institution that applies, not individuals.
Correct.
Good.
Brian Rudkin, speaking from Lyon, France. So very interesting, very concise presentation. Thank you very much. If I've understood correctly, the purpose here is to describe the change in policy for granting foreign institutions. Now, in European grants, when we're in that sort of a situation, the foreign institution also must justify covering a portion of the expense. It cannot be 100% of the cost of the foreign institution is covered by the grant. Okay, so in other words, you have to put in what are the salaries with overheads of the people participating in the project and things of this nature. Is that the case with this type of the grants that you are talking about?
Okay, so an NIH grant is an assistance mechanism. It was never designed to pay the full cost of the research. So even domestically in the US and stuff, we provide funds for salaries and supplies, and it could be potentially 100% of what they need. But the fact that we only pay 8% in F&A for compliance purposes means that they're going to probably have to provide some infrastructure costs of their own to make it happen.
I understand, but there's not a requirement. For example, in order to get 100 from Europe, no, in order to get, if my project is a cost of 100, Europe will only give, for example, 50%. I have to justify that I have the 50% other in terms, for example, in terms of salaries. That is not the case with NIH, is what you're saying.
Correct. That is not the case. So
okay,
just say you need $100,000 to do your research. At NIH, you could actually request $100,000 for salaries, supplies, reagents, animals, whatever the case might be.
And you put your finger on another aspect that's strategic. The use of funds is highly regulated, and usually people use the overhead in Europe to cover the things that are not allowed in the actual main lump sum. So in the case of NIH funds, you just mentioned that it can be used, again, within the limits that you just described for almost anything within reason.
There are cost principles at NIH. You can look in the NIH policy information that says what we can provide. In other words, there are limitations of what we consider an allowable cost at NIH, and it's not all there are gray areas in there, but we give you very good guidance on what can be charged. And so there's certain things that can be charged and there's certain things that can't, and you can't do that. And if you want to use that money in another way, you have to either, if you do use that money in an erroneous way, we can ask you to reimburse us.
Of course.
Or if you are doing it in certain charges that you say you have to do, we just won't give you the money. So we give 8% F&A or indirect costs, but that's actually for compliance purposes. So there are things we need to pay for. So in some ways, we pay for certain things, and then the institution will have to find money to do the rest.
And final question in this regard, that I've had with in the beginning with European grants. It's the actual exchange rate. How do you work that out? That the cost is accounted for when the money is transferred, and that's how you do it?
Yes.
In some countries where you have an inflation that is going up or a deflation, that can play in one direction or the other. So how do you account for that? Because that's a very strategic aspect.
Yeah, so when they, for example, if it's a direct award to a foreign institution, when they draw down the money, that's the exchange rate that is used. Okay. Or potentially when it's a domestic institution and then they send over the money, that exchange rate is what's used at that time. In the past, actually, prior to a couple years ago, and we would not normally consider any problems or issues with volatile exchange rates. Sometimes they go down, sometimes they go up. But the current policy is that we can actually consider these things potentially to provide extra money if the case is severe. We can consider that. It's really based on availability of funds.
Thank you very much for the concise responses.
Sure.
Much appreciated.
Now, I do have some extra slides, so if people don't have extra questions, we can finish the slides that we have.
Yeah, let's maybe go through the slides and still give the opportunity to ask questions.
Right, sounds good.
And feel free, everybody, to post your questions in the chat.
Yeah, so Vicky has posted some things in the chat. She put a link to the NIH grants policy statement, which we consider our grants Bible, and a couple other links. This section on helpful tips and resources, these are common things that we see, things that we see that help people when they're starting to apply for NIH grants. So I'll just go through these slides. Hold on a sec. Are there any tips to assist foreign institutions while registering in ERA Commons? ERA Commons is actually a system that's developed by NIH to help get everything situated to do a grant award. But applicant their key pointers in mind for registering in ERA Commons. Applicants, organizations must have a SAM issued UEI. So a UEI is a very important number. It's now required. Unique entity identifier prior to the registration in ERA Commons. You need to complete the full SAM registration to begin the ERA Commons registration, though it will need to be completed prior to submission. The same UEI must be used in all the federal systems, SAM, grants.gov, and ERA Commons. Are SAM and grants.gov registrations required for a subaward or consortium? Subaward consortiums, organizations do not need to register in grants.gov or complete a full system for award management or a SAM registration. However, they may need to apply for a UEI in SAM. So UEI is required. Is a UEI number required for every sub-award or subcontract organization? Yes. The organization UEI is required field in the research and related budget for both the applicant organization and subawards. Applicants should make every effort to provide an accurate UEI number for all subaward or consortiums. Some of the data fields in the SF R2 424 R&R form, that's the form you use to submit the application, do not really apply to foreign organizations. How will they be handled? For some data, special instructions are included in the application guide for foreign organization. For example, are international organizations required to obtain an EIN number as part of the grant submission process? If the grant has an NIH grant, has had an NIH grant, the notice of award or the award that you got should contain a valid EIN number. So the first thing you have to think about if you're a foreign institution, you're applying for an NIH grant, you need to look and see if you've ever had any NIH grants at that institution. And if you had, then you actually have an existing EIN number, which is an NIH generated number kind of to track the institution. So you can look for that as part of an award from an NIH grant if you've had a direct award before. If a grantee has not had an NIH grant, NIH does not require the international organization to obtain an EIN number for application submission. International organizations can use, all fours in that field for the employer identification field in the 424 application package. How do I know if a foreign organization is eligible to apply? Now, each funding opportunity or NOFO has a section called for eligibility. In that section, there will be a clear statement about whether or not foreign institutions are eligible to apply. Which budget form should I use if I'm a foreign organization? You must use the research and related budget form. On the SF 424 application, there's a field called state that appears to be required. What do I do? If you select your country, if you select a country other than the US or Canada, the state field will become optional, so you don't fill that out. The inclusion of a province is required for Canada, grants coming from Canada. How does the system handle phone numbers in different formats? The phone number field on the SF 424 app has a 25 character limit, but no specific format requirements. Also, there's a field that says, what should I include for congressional district? The congressional district is for the U.S. institutions to fill out, and it just basically says what congressional district you are in the U.S. Foreign institutions should put all zeros for the congressional district. Okay. So Nelly, pull up chat, see if there's anything else. So I don't see any other questions. Would anybody like to ask any questions?
Hi, Bruce. I posted another question that I often hear. So NIH grants function on a reimbursement basis, and I apologize if I don't have the vocabulary quite right.
Right.
But if an institution is a in the US is a prime, we have a mechanism now, not without difficulties, where we could advance like 2 months of equivalent to LMIC institution. But if an LMIC institution is a prime, they don't have the money. Is there any other mechanism from NIH where they would be able to get some money ahead of time instead of just being reimbursed for their costs?
Okay. So first, there really is no requirement for reimbursement. So if it's a direct award to a foreign institution, they draw down money in advance, just like U.S. institutions. So they can draw down money ahead of time to pay for the bills. If it is a subcontract, if the foreign is a foreign subcontract to a domestic U.S. award, they also can be advanced money ahead of time, just like the U.S. And I did provide that information in the slide earlier, and it's also on the Fogarty FAQ website for grants. And basically, it's up to the institution. Now, some institutions think that they have to do a cost reimbursement. That is incorrect. I know that some institutions have a little more aggressive policy as far as a payment and that type of thing. Maybe in the past they had been burned or gave money to an institution and then they never got anything back from them or whatever. But it's actually the institution, the grantee institution's policy that can make it more restrictive or more flexible. There's no reason that a domestic institution like Harvard cannot advance funds to a Cape Town university or another university if they have a subcontract. You have to look at that, talk to the domestic grantee, work it out in the consortium agreement, but there is no requirement to do a reimbursement basis.
Yeah, thank you so much for that answer.
So here are some extra references and links that that we gave you just for NIH and foreign grants. We give you some really good links here for opportunities. And it's just, these might be very helpful. Some of the things we discussed before. We also have a funding news email that we have at Fogarty. We have FIC and foreign funding opportunities. So that's where you can find some of those. And then here's some links to the systems, the payment management system, and some general questions, if you have them.
One more question, if you don't mind.
Sure, of course.
Are there some areas of focus for the NIH, particularly for foreign countries or the LMICs?
Okay. You mean are there certain countries that are focused or certain areas?
Not necessarily countries, but subjects of research or subject of
okay, that's actually a really great question. You know, it depends. I would say, like, for example, if you're working with a U.S. institution, you could find out what areas they're interested in and then kind of cater to that. If you're going directly as a foreign institution, what you can do is a lot of times it would be your country's
Can we close the door,
priorities.
please?
I'm sorry. So a lot of times, like at the different institutes at NIH, they all have different portfolios and things that they're interested in. And at Fogarty, you can see our programs are all solicited, so we don't take unsolicited grants. So it's only certain areas that we provide money for. But you actually can do a data search about like what's being funded by the IC if you're in a certain area. Just say you're doing cancer and you're doing brain tumors. You can actually look at what's being funded. Obviously, you don't want to put in an application for something that's already being heavily funded because first off, they might want to fund a U.S. institution before they'd fund a foreign institution. And you also can call the program officers at the different institutes. And that is actually really a great way to see what interest they have. If you're, like I said, if you're doing cancer, you might want to talk to the staff at the Cancer Institute. If you're working with AIDS, NIAID or Fogarty, you might want to talk to see what kind of, questions and fields, and you could do some data searches as far as what's being funded, what's not being funded, what might be exciting. So you definitely can have resources and talk to the staff at NIH too, to see what might be of interest to the Institute. I mean, if you're just doing basic research, there might be a lot of basic research being done in that field already. So you really need to tailor your application to have interest. I used to use the example of if they were doing clinical trials and just say in South America, and maybe you teamed up with a institution in Florida and Miami that had a big Hispanic population, and you could do a comparison study, these types of things. There's a question, how about, are you talking about SBIR grants? And are they accessible to international innovative companies? No, the SBIR grants have very specific rules. I mean, I wouldn't want to go into detail here about that. You would really need to look at the rules on that. It's very specific about how the SBIR grants.
The reason I ask this question is when I go to your site, I see a lot of funding for oncology, for AIDS, and in this age of digital technology, one is wondering whether there's the interest in digital health technology to rural communities.
Oh yeah. There's I know there's informatics programs, and we have a person on our staff that at the program officers at Fogarty that deals with that. So yes, we actually in the past have had informatics programs and yeah, there's quite a bit of information on that. Now, whether there's current programs that you can apply to is something totally different. You have to find opportunities to get funding for that. So I don't know which programs potentially. I mean, you could always go to there's something called the NIH Guide for Contracts. And that's where you can search for opportunities or NOFOs. And in there, you could put, some keywords there that might help you, like international and, data health systems and that type of things. I know there's projects being funded in that field.
Useful, thank you.
One of the issues of European grants, you mobilize a lot of people, many different countries. You respond to a specific call, and I think it's anywhere between 1% to 6% are actually funded. If you're really lucky, it's 10%, but generally it's very low funding percentages. First question: is there a general number, or is it highly variable throughout NIH, depending on the institute that or the type of grant you're requesting? That's the first question. The second is another issue with regard to European grants. Once it's refused, they don't ask you to come and make it better. You've lost all of that investment of time, of enthusiasm of all of these people, and it's essentially flushed down the toilet. It's a huge waste of energy and a great wealth for the consulting firms that are hired to help write these grants because they're impossible to write. How is it with NIH?
Okay, so the funding levels for different programs is very variable between each institute has a very different funding rates, and with Fogarty, we actually for each of our programs it's different. We try to get to the 10% mark if we can, or even higher sometimes, depending on the program. So each institute is different, and and there's also different pots of money you can go for it. In the office of the director, there's AIDS money, there's women's health money, there's OBSSR and that type of thing that also provides funds that can be very attractive. So certain grants, obviously there's a huge amount of AIDS money available at NIH. Some institutes even have a problem spending all their AIDS money, to be honest. So it is very variable. Vicky just posted the NIH reporter, and that actually can tell you about money and funding. Like I said, each institute has different pay lines, and sometimes pay lines for different areas, like a small business grants for domestic institutions might be one pay line. A regular R01 pool at a big institute might be another pay line. So it is very variable. At some points, it is very tough. At a big institute, you might put in a grant and only like 6th percentile, but at Fogarty, it might be a 12th percentile get in. So it is very variable. What was, I'm
Okay.
sorry, the second part of your
The
question?
second question was very straightforward. In Europe, once you've mobilized, you know, 20 groups around Europe, you've worked, you know, for months putting it together, you submit it, it's refused just by a hair. It's refused, and you cannot go back and resubmit because the program is no longer valid. The call is stopped. How about in with the NIH funding?
Okay, so let me give you the kind of this kind of perspective. So about a little over 80% of the NIH grant funding is unsolicited. In other words, people have ideas, they submit it into these announcements that are very open, and it's people come up with ideas and they put the applications in. The other 15 to 20% are usually solicited. In other words, very unique things. There's a call, there might be deadlines, or there might be a 3-year deadline, 3 years in a row deadline, these types of things that might get renewed. Now, grants that come in, I'll just take an example. Just say you had an idea and you put in, and you go to your institution and you put in a grant application. Well, it comes back, and if it's kind of good enough to get a review, we only give kind of really detailed reviews on about 50% of the applications that are submitted to NIH. If you get what's called a summary statement back, it tells you kind of what happened and what they think of it. If you didn't get scored, if you got scored, if you didn't get scored, you sometimes will get also feedback, some really kind of just rough feedback. But the summary statement gives you more detailed feedback. So then it allows you to come in with another amended application to that. And then if you submit that and it doesn't go, you can actually resubmit it again as a new application. So people sometimes come in 3, 4, 5, 6 times even just through that process, and they kind of basically can really fine-tune their application and try to fix what's wrong with that, so that we don't really lose that investment per se. So what is the most effective place to write for information on the funding of clinical trials for HIV? So obviously you can go in to Reporter and actually, and that link she put in just a few minutes ago, a little above, and you can do some data searches there and find information on clinical trials for HIV. And so
great, thank you very much.
Yes,
very effective as usual.
And actually, if you you have specific questions, you can call the staff at NIAID and have a discussion with them. Potentially, like, for example, just say there's a solicitation out there and you want to discuss it a little more in detail. You can call the program officer staff assigned to a NOFO and or that, and try to get some more details. Some people think that you can't reach out to NIH staff, and that's not true. Especially the program officers a lot of times are very eager to help people that are interested in doing some cutting edge research.
Thank you very much.
Very delighted that you give us this information. Some of us are interested in digital health in rural Africa. And I don't know whether this is something that NIH or Fogarty be interested in supporting.
Right. Well, we do have several programs. I encourage you to look at the programs we have, and we've had in the past actually too. So I don't know if it's kind of right in line with what you have, but like I said, I know there's other maybe trans NIH type grants that might be applicable. So you could reach out to maybe the program officer that had, of mobile health technologies. That might be something. I'm sure we have grants in there that are dealing with that.
Thank you. Thank you.
Okay, so I know that we still have lots of questions, and we could be here and keep discussing it for much longer. But on behalf of the CUGH Global Health Operations Committee, I would like to thank Bruce and Victoria for their very informative sessions and answering all of our questions. Thank you so much to all of the attendees. Would you mind? I'm just going to share one more slide. My apologies from the, okay. So again, thank you for attending our session, informing our agenda and priorities for the year to come. I would like to encourage you to stay involved, follow our committee, visit our website, visit the website of CUGH and look at the activities of other committees. And I would also like to invite you all to the CUGH conference in March 2024 in LA, California in the United States. The committee will be holding in-person session on breaking down barriers, navigating technology access disparities, and ethical imperatives for equitable and sustainable global health operations. So maybe some of the discussions we had today can be again advanced during that discussion. Thank you so much, everybody. The link to this recording will be posted on the CUGH website. Again, many thanks for attending and engaging in the discussion. If you have any other questions, please feel free to reach out to the committee members and specifically to the two co-chairs, myself, again, Anna Helova and Richard Wamai. Thank you so much, everybody. Thank you.
Bye.
Thank you.